So hello everyone and welcome to our new webinar that is part of our Young ESPGHAN Webinar Series. Today we are going to talk about a very interesting topic. We are going to talk about the intestinal ultrasound and seeing beyond the lumen. And we have here today a special guest. We have Dr. Luis Rodrigues, who is going to let us know about more about the intestinal ultrasound. So I will be your moderator today. My name is Mara Ionescu, and before we go ahead with our presentation today, I'm going to start with a short introduction about Young ESPGHAN and what is our mission. So without further ado, I'm going to start if my presentation will actually work. So what is our Young ESPGHAN committee mission? First of all, is to promote high quality research and training, to organize different activities for our Young ESPGHAN members, but most important is to represent our interest within the council and the society. We have different educational events that we organize throughout the years. The first one, for example, is our Young ESPGHAN mentorship program, where it's a form to meet and receive support from more senior ESPGHAN members. This year, the deadline is on 15th of March. So please, you still have a bit of time to register for this mentorship program. It has been going on since 2017. Last year, we had 12 pairs. And there will be also a meeting in person during the annual conference. So it's a great opportunity to receive advice from senior members in ESPGHAN. We organized during our annual meeting our Young ESPGHAN Day. Last year it was on Wednesday, on the 14th of May in Helsinki. We had a great time talking about decoding research, about systematic reviews, meta-analysis, and peer review essentials. Also, we organized a reviewers program, which ended in 2 webinars, and you will also get a certificate for the ones that participated in this program. And we finished our day with a Young ESPGHAN session with immersive painting. And here you can see that we had a great time, and also our paintings were a real success. Last year, we had a new session. We had the expert dialogues, navigating clinical cases for young professionals, where we had the opportunity to present one of your most interesting cases, and you got some advice from senior members. Also, this year, we are going to have another interesting session. We are going to talk about some guidelines. So please just go, when you register for the annual meeting, please just also attend to this session, and also try to register for our Young ESPGHAN Day. We are going to have many great surprises, and we are going to talk about a very difficult theme. We are going to talk about statistics this year. Also, during every annual meeting, we have the Meet the President event. Here in this picture, you have the former and the current president of the Young ESPGHAN. We had a very special meeting last year, and this year we are going to have it again. This event gives us the opportunity to ask questions and to learn more about ESPGHAN and give ideas to improve our organization. There are several upcoming educational events. You can find out more by going on our website and clicking on courses. For example, we have the Eastern European Summer School, Training the Colonoscopy Trainer Study Day, Nutrition Summer School, the Summer School, the Gastrointestinal Summer School. For some of them, you can still apply. So I encourage you all to apply and attend all these courses that are absolutely great. So who is our team, the Young ESPGHAN committee team. So we have Anne-Marie, who is our chair. We have Vangelis, our secretary, Petra, our treasurer, Francesca, that's our social media guru. We have Pinar, our international affairs officer. You have myself, Mara, and Jose. And also you have our GIC, nutrition and HEPCOM representatives, Giovanna, Harwin, and Beno. We are also going to receive some new members, and unfortunately, some of our current members are going to leave us. So if you're not a member yet, please join us and become a training member. You have so many benefits, from just the simplest subscription to JPGN Online to different research grants, access to different research grants and awards, and the possibility to take part to many educational events. So you only have advantages. How to become a member? You need to fill in an application form, which you can find on the website. You need a CV and also a letter of support from a full member not serving in the council. If you want to find out more about our Young ESPGHAN committee, but also about ESPGHAN, just download the ESPGHAN app. And also you can follow us on Instagram. Regarding our webinars, we have exciting new topics. Next month, we are going to talk about pediatric polyposis syndromes, from genetics to endoscopic management. Then in May, we are going to talk about Wilson disease, about early clues, timely diagnosis, and modern therapies. And in June, we are going to talk about the low FODMAP diet, unlocking relief for IBS in children. So join our upcoming Young ESPGHAN webinars. So without further ado, I would like to introduce our speaker today, Dr. Luis Rodrigues, who is working in the gastroenterology unit at the Hospital de Santa Maria in Lisbon, Portugal. He is certified in intestinal ultrasound by the International Bowel Ultrasound Group. He is also a member of the ESPGHAN Intestinal Ultrasound Special Interest Group. And of course, he's an ESPGHAN trainer in intestinal ultrasound. So you can see that he has great experience in intestinal ultrasound. So hopefully he's going to share some of his great experience with us. It's a very interesting topic. It's very useful and has become even more accessible nowadays. So thank you so much for accepting our invitation. And for the participants, if you have any questions, just please try to write the questions in the chat, and we are going to read them at the end.
So, is it okay, Marit? Can you see it, everything?
Yes, it's perfect.
Yes. So good afternoon, everyone, and thank you very much to Young ESPGHAN for the invitation. My name is Luis Rodrigues. I'm from Lisbon, Portugal, and today I will talk about intestinal ultrasound in inflammatory bowel disease and how this technique allows us to look beyond the lumen and better understand what is happening within the bowel wall. Over the next hour, I will briefly review the rationale for intestinal ultrasound, the main parameters that we assess, how it can be used in clinical practice, and finally, I will show you two short clinical cases so that you can see how we can integrate intestinal ultrasound in our daily practice. So to start, let's briefly look at how the goals of IBD management have evolved in recent years and how intestinal ultrasound is part of that right now. In the last decades, the management of IBD has changed significantly, and according to the STRIDE 2 recommendations, the goal is no longer symptom control, but instead we aimed for sustained deep remission. And in Crohn's disease, this includes clinical remission, endoscopic, and ideally transmural remission, and in ulcerative colitis, clinical, endoscopic, and ideally histological remission. And achieving this requires early initiation of effective therapy, regular disease activity monitoring, and therapy adjustment based on predefined therapeutic targets, which is the treat to target strategy. However, monitoring disease activity frequently is not always easy with the tools we traditionally use. And for example, colonoscopy, although it is the gold standard examination for IBD monitoring, it has several limitations, particularly in pediatric patients. First, the terminal ileum cannot be intubated in around 50% of patients, which is especially relevant in Crohn's disease. Second, the procedure is invasive. It requires bowel preparation and usually sedation or anesthesia. And finally, because of discomfort and logistics, it is not ideal for frequent monitoring. And this is exactly where intestinal ultrasound becomes extremely valuable. Intestinal ultrasound is a non-invasive imaging technique that allows us to real-time visualization of the bowel wall and surrounding structures. Importantly, it does not involve ionizing radiation, which is particularly relevant in children who often require repeated imaging. And several studies have shown an excellent correlation between ultrasonographic inflammatory activity parameters and endoscopic and radiological findings. And because of these characteristics, intestinal ultrasound offers several advantages in daily clinical practice that we can use. First, it is safe and completely radiation-free, which is extremely important in children and adolescents who often require repeated imaging, often over many years. Then, intestinal ultrasound has excellent diagnostic accuracy for detecting inflammatory activity, and in many clinical situations, its performance is comparable to other cross-sectional imaging techniques, such as CT or magnetic resonance. As you can see in this systematic review published last year that included more than 170 papers and more than 10,000 IBD patients, you can see that they measured the pulse sensitivity, specificity, and accuracy, and comparing it, the accuracy from intestinal ultrasound to the one from magnetic resonance and from computed tomography, you can see that it's pretty similar. Another key advantage in its role, it's treatment monitoring. And because ultrasound allows real-time visualization of transmural inflammation, it can be used to assess therapeutic response early and to guide treatment decisions together with biomarkers and clinical evaluation. In this study, which included 44 patients with Crohn's disease, they monitored the intestinal ultrasound parameters in children who achieved the treat to target endoscopic remission and the ones who didn't. And as you can see, in patients that achieved treat to target remission, the parameters such as hyperemia, the bowel wall stratification, the inflammatory fat, and the lymphadenopathy, they are all reduced. And according to the evolution that we were expecting, and in patients who did not achieve endoscopic remission, the parameters for except of lymphadenopathy remain the same. It's also interesting that from the patient's perspective, ultrasound is also very well tolerated. The examination is non-invasive and does not require bowel preparation, fasting, or sedation, which is particularly important in the pediatric population. And in this study, where they compared the discomfort that patients would feel with ultrasound, magnetic resonance, or the endoscopy, as you can see, the discomfort from ultrasound is way lower than the others. And if you ask the patients which tests would you mind least to undergo on a regular basis, these patients responded that ultrasound was the one they would prefer, comparing to sampling tool or venipuncture. And when they asked which test would you mind most to undergo on a regular basis, ultrasound was the least picked. And finally, for the cost effectiveness, ultrasound is a relatively low-cost imaging modality, making it a sustainable option for repeated monitoring in routine clinical practice. And we can say that because of these characteristics, intestinal ultrasound is particularly well suited for tight monitoring strategies in pediatric IBD. And with all of this said, right now we can ask, when should we actually use intestinal ultrasound in our clinical practice? And basically, we have two main clinical scenarios. The first is in patients without confirmed diagnosis, for example, patients with suspected IBD. And in these cases, intestinal ultrasound may detect findings such as bowel wall thickness or other markers of inflammatory activity, and will help to guide further investigations. And the second scenario is in patients with an established diagnosis of IBD, where ultrasounds can be used to monitor disease activity, to detect complications, and also to assess treatment response. Historically, it was thought that it would be only useful for Crohn's disease, but right now we know that we can use intestinal ultrasound not only for Crohn's disease, which have a transmural affection, but also for ulcerative colitis, and that these parameters can also be different in this type of disease. And the later guidelines of ECHO and ESPGHAN reflect this important part of intestinal ultrasound, not only in Crohn's disease, but also in ulcerative colitis, that you can see that it is recommended to assess transmural involvement as an alternative to magnetic resonance to monitor the disease in Crohn's disease. And ulcerative colitis, it should be combined with the PUCI and the fecal calpro to monitor disease. But of course, it has to be done by someone who has expertise on this type of technique. We also have to be aware of the technical considerations, and the examination itself is relatively simple and well tolerated. Ideally, it should be performed in a quiet and dimly lit room, which helps improve image quality. Also, in children, parental presence is encouraged as it helps to reduce anxiety. But from my experience, I don't think that children aren't really anxious about this type of procedures, and they really like to do it. And it really helps if you try to find at the ultrasound what they have for breakfast or something like that, and they will be eager to find it on the image. Also, the patient should be in a position supine with the abdomen exposed, and really important, fasting is not required. Also, the choice of ultrasound probe plays an important role. When performing intestinal ultrasound, we usually start with the convex probe, which is this one, that provides deeper penetration and allows a general overview of the abdomen. With this initial scan, basically what we're trying to do is to identify bowel segments identify the bowel segments and detect any obvious abnormalities. And then we change to the linear probe, which has a lower depth penetration and a higher spatial resolution, and will allow us to a much more detailed evaluation of the bowel wall, including bowel wall thickness, bowel wall stratification, and then we can use the B mode, but I'll talk about that later, to search for vascularization. In some cases, also a microconvex probe can also be useful, as it offers a compromise between depth penetration and spatial resolution, and particularly in smaller children or in more difficult anatomical areas. For example, when you're trying to do a transperineal approach to see the rectum, you can use this microconvex probe that will help you to see a better image. Then, talking about the technical aspects, one of the things that people ask me the most is if the examination duration will take much more time than we usually have to see these patients. And usually it takes 5 to 15 minutes, depending, of course, on the diagnostic question and findings. Of course, if you are performing a study, or if you need to do more measurements, it will take longer. Or if you find any complication, it will take longer. But you can easily integrate this procedure in your regularly clinical appointments. Then you have to perform a systematic scanning approach. Usually we have as a marker the bladder, and then you can start for your by right or by left. Usually I start for the sigmoid colon, then I continue to the descending, transverse, ascending, and then to the terminal ileum. And this we do first with the convex probe. Then we scan all of the abdomen to see if there are anything that catches our eye, to see if there's something different. And then we do it with a linear probe to check and to assess the parameters that we're going to talk in the next slides. I would also like to tell you about this graded compression method. If you start and you compress a lot the abdomen of the patients, then you will have difficulty to see the bowel wall, and this is important because it will help when you're compressing lighter and then a little harder. It will help displace the bowel gas and improve visualization of the bowel wall. Of course, for like any other technique, image technique, these have potential limitations. And we can talk, one potential limitation is the reduced image quality in patients with thick abdominal adipose tissue. And in these cases, using a lower frequency probe can improve the depth penetration and help optimize the visualization. Another challenge is the visualization of the rectum, because it's difficult to visualize with the standard transabdominal ultrasound. And in selected cases, a transperineal approach may be necessary, or another complementary imaging modalities to such if there are any complications of this anatomic area. Also, visualization of the small bowel can also be challenging, especially the proximal part of it. And it can be differentiated from the colon because it has a greater motility and the absence of colonic ostra. And for this, the systematic scanning is really important to use the same parameters every time you perform intestinal ultrasound. Also, in patients with penetrating and stricturing disease, ultrasound can be able to detect many of these complications. And as I said before, a systematic anatomical scanning approach is essential. And in some situations, or when you have any doubts, you can have another type of image like MRI or CT scan. What I want to say here is that intestinal ultrasound is not a substitute for the other type of images, but it's complementary. And finally, as with any ultrasound technique, operator training is crucial. And the International Bowel Ultrasound Group and ESPGHAN have already developed some training curricula, which I will talk about later in this presentation. And of course, if you want to join us in the ESPGHAN curriculum, you are very welcome, and I will explain everything to you. So to interpret the ultrasound findings correctly, first we need to review the bowel wall anatomy to understand the normal appearance of the bowel wall. And on ultrasound, the bowel wall typically shows a layered structure that we can see in here in this image, which is composed of 5 layers alternating between hyperechoic and hypoechoic bands. When we are talking about hyperechoic, it means that it's wider, and when we are talking about hypoechoic, it means that it's darker or blacker, if you want. And as you can see, this in the lumen will appear white on intestinal ultrasound. Then you will have the bowel wall that will include the mucosa, submucosa, and muscularis propria, and then we'll have the serosa. And in this image below, you can see this correspondence. Then we will have here at this white line, we will have the lumen, and then we'll have the mucosa in a black band. Then we will have the submucosa in a lighter band, and then we will have the muscularis propria. Okay, this is an image of the terminal ileum, and now we are going to see the parameters. And as you can see also in this image, in IBD, the architecture may become thickened. Comparing this normal image to the one in IBD may become distorted or even lost, depending on the severity of the inflammation. When performing intestinal ultrasound, several parameters are systematically assessed, and these include the bowel wall thickness, the bowel wall stratification, the bowel wall vascularization, and of course, other parameters that are outside the bowel, which is the mesenteric fat hypertrophy or inflammatory fat, the mesenteric lymphadenopathy, the small bowel peristalsis, the colonic ostra, the free fluid, and the complications that include the strictures, the fistula, and also the abscesses. And right now, I'm going to start with the bowel wall thickness, which is one of the most sensitive indicators of intestinal inflammation. And as you can see here in a cross-sectional image, here we have an image of the bowel, and here we have a longitudinal image, and this is the bowel wall. And one of the main difficult parts of this evaluation is to measure the bowel wall, and we use the layers that I've said before, the mucosa, the submucosa, and the muscularis, and we go from the lumen to this part, and this is the bowel wall. To remember this, we usually use the Oreo cookie, and as you can see, black, white, black, black, white, black. Remember this when trying to measure the bowel wall. In healthy children, it is the bowel wall thickness is usually below 2 to 3 millimeters, although values vary across studies. And in inflammatory bowel disease, increased thickness reflects transmural inflammation, and it is usually above 2.5 to 3 millimeters, but not like in adults that we have a specific cutoff that if you have more than 3 millimeters, then it reflects inflammation. Here in pediatrics, even though we have a meta-analysis that included 14 studies and the range of bowel wall thickness from 1.5 to 4 millimeters, there are no generally accepted cutoff values, but we usually consider that it is inflammation above 2.5 to 3 millimeters. In addition to thickness, the structure of the bowel wall is also very informative. And here we have the bowel wall stratification. In this first image, you can see that the layers that we have talked before, they are maintained. You can see right again, black, white, black, mucosa, submucosa, muscularis. In here, in the second image, you can see that is a little blurred, and you cannot differentiate from one to another. So we would say that certification is uncertain. And in the third and the fourth image, you can see that there is a loss of certification and that we cannot define the layers that we have talked before. And if the loss of certification is less than 3 centimeters, then we say that is a focal loss of stratification. If it has more than 3 centimeters, then it is extensive loss of stratification. And of course, this is a longitudinal image. Then we have bowel wall vascularization, and the color Doppler allows us to see this. First, we were at the B mode, and then we changed to the color Doppler mode. And the more Doppler we have, the more inflammation we have. And use the modified Limber score to classify the vascularization, and it can range from Limburg 0, where there is no signal, to Limburg 3, where we have long signals inside and outside the bowel. I'm going to explain it. I'm going to be a little more specific. So in here, you can see that when we use the color Doppler, no signals appear at the image. Then when we have Limburg 1, we see small dots at the bowel wall. As you can see, this is the lumen. This is the anterior wall of the bowel, and this is the posterior. And you can see small dots inside the bowel wall. In Limburg 3, you can see that this is, you have long signals like lines that go inside the bowel, and in Limburg 3, you can see that these signs go through the bowel wall, and then we have a Limburg 3, okay? If we talk about other parameters like the mesenteric fat hypertrophy, also known as creeping fat, it is frequently seen in IBD and it reflects chronic inflammation. Here you can see that around the bowel, you can see that it's lighter, that is wider, and it's like a wrapping tissue that goes along with the bowel. Then we have mesenteric lymphadenopathy. When large mesenteric lymph nodes are also common, and it may support the presence of inflammatory activity. And here you can see there are these small images here close to the bowel. Then we have the small bowel peristalsis, as you can see in this image. Reduced or absent peristalsis can indicate inflamed or fibrotic segments. And in here, you can see that it moves, and it usually moves more than the colon. And it also has an interesting appearance that it looks like a fish spine that goes in here. Let's continue. I'm sorry, I'm just going to turn on the pointer again. In here we have the colonic ostra, and as you can see, it looks like a cloud pattern, as in here. You can see, and this here is the painted image. And when there is loss of ostration, it may be seen when we have colonic inflammation. Also, if we have free fluids, it can be found, and particularly during active disease. And you can see that is anechoic image here, a black one that has his limits really defined. And this is the scheme close to it. This is the terminal anem. Then if we have a stricture, ultrasound can really identify this type of complication, and it's typically characterized by luminal narrowing, bowel wall thickening, and upstream dilation that we can see here in this image. You can see that it's narrow than in here. Then the bowel wall is also thickened, and you can see the dilation in here that that we have also in this image. Also, the fistulas appear in hypoechoic tracts. In this image, we have two. You can see them in here. And also, they can have small dots, some small white dots that correspond to air bubbles in the fistula. And usually, they connect bowel loops or other structures. And here they are really well identified. And also there is the abscess that are some images that usually look hypoechoic, that have no defined limit, and that can also have white dots inside of it that reflect the air bubble, and it's really close also to a bowel segment. Because ultrasound provides multiple parameters to assess, we can several ultrasound scores have been developed, and some promising advances have been reported in this area. Unfortunately, we are a little behind the others that have a lot of validated score activities. But in pediatrics, we have 4 ultrasound scores that are validated, and that will help us to manage and to compare our exams between evaluations and with other colleagues. We have the Civitelli ultrasound score that will help to characterize this inflammation in ulcerative colitis. We have the ulcerative colitis intestinal ultrasound score for ulcerative colitis, the pediatric Crohn's disease ultrasound score, and also the spouse. They will help us with both of them. but right now we still need further external validation, and this will be possible with multi-center prospective studies that are required. And one of the most exciting application of intestinal ultrasound is disease monitoring. And in clinical practice, ultrasound is often performed at baseline, usually around the time of diagnosis or at the time of colonoscopy, in order to establish a reference assessment of bowel inflammation. And it can also be performed when initiating a new therapy or when making a treatment change, providing a baseline for subsequent evaluation or treatment response. A follow-up ultrasound is typically performed after induction therapy or approximately 4 to 12 weeks after treatment initiation or change. And at this stage, we assess for improvement in key ultrasound parameters, namely the bowel wall thickness and the vascularization. And if there is no significant improvement, treatment escalation or optimization should be considered. And conversely, if ultrasound findings suggest worsening inflammation, then a change in therapy may be necessary. Ultrasound can also be repeated around the time of treat-to-target colonoscopy, helping to correlate transmural and mucosal healing. And if we do not achieve treat-to-target, if there is no mucosal or transmural healing, then we should reevaluate. More or less the 4 to 12 weeks after treatment change. Or once therapeutic targets have been achieved, intestinal ultrasound can then be used for serial monitoring, typically every 3 to 6 months, as part of the routine follow-up. In this image, it's basically the same as I have shown you before, but here we showed the concept of intestinal ultrasound response, intestinal ultrasound remission, and intestinal ultrasound non-response. These numbers come from the adult's experience. And it is considered intestinal ultrasound response when we have a bowel wall thickness decrease of more than 25%, or if there is a bowel wall thickness decrease of more than 2.5 milliliters, or if there is a bowel wall thickness decrease of more than 1 millimeter, and a decrease of more than 1 point in vascularization in the color Doppler sign. And if we have ultrasound remission, then we can say that bowel wall thickness is below 3 millimeters and there is no vascularization, so we would have a Limburg of 0. And if we say that we have an intestinal ultrasound's non-response, then we would say that bowel wall thickness is unchanged or increased from baseline, and we have a color Doppler sign unchanged or increased from baseline. But as you can see, these parameters come from adults. And as I told you before, we use, right now we're using from 2.5 to 3 millimeters as a bowel thickness reference. It is also important to talk about the reports because a systematic structured report ensures a consistency and communication between the sonographer and treating clinician. For example, if you are the one in your unit performing intestinal ultrasound, then other colleagues will ask you to perform these examinations, and you need to have a clear communication, and you need to be clear so that everyone is speaking the same language. Also, it enhances follow-up quality and reproducibility in future assessments or studies. And as a recommended report structure, we should write the clinical indication for the examination, the reference to prior imaging and endoscopic studies, relevant surgical history, the assessment of study quality, noting limitations, for example, the body habitus, the gas interposition, etc. And we should describe all of the findings, even if they're positive or they're normal. And then we should write a basic conclusion with the interpretation and the diagnosis. This is an example of the standardized report. And as you can see, then we first go on every segment of the bowel, and then we finish with the TI and other findings that we might find in other parts, and we should also register complications and other findings. And to illustrate how ultrasound can be used in clinical practice, right now I would like to show you two short clinical cases. I don't know if it will be possible for you to enter the conversation, but at least you'll be able to analyze this image and to analyze this clinical case. So we'll have a 6-year-old boy that was previously healthy, and he presents with a 3-month history of intermittent abdominal pain, chronic diarrhea with 4 to 5 loose stools a day, and occasionally nocturnal, with reduced appetite and weight loss, fatigue and decreased activity. There was no rectal bleeding reported, and there was a low-grade fever during the previous week. On physical examination, he had weight below the 10th percentile, and previously he was on the 25th percentile. He had mild pallor, no palpable abdominal mass, and the perianal inspection showed a small skin tag. On laboratory findings, we found an hemoglobin of 10.8, a CRP of 2.8. The erythrocyte sedimentation rate was 42. The plaque was 520. We had this hypoalbuminemia, and the fecal calpro was 1,250 units. And this was the intestinal ultrasound, and this is from the transverse colon, but it was basically it was pretty similar all across all the segments. And I'm going to ask you, and I'll give you some seconds to think about that. What pathologic findings can be identified in this image?
I think they can write the answer if they want in the chat, so that you can
Yes, of
write.
course. So I'm going to help you. And in this first image, as you can see, so this is the bowel, of course, and then we have, this is the anterior wall, and this is the posterior wall. In this lighter line here is the lumen, and then you can find here mucosa, submucosa muscularis. And as you can see here, we have two measurements, 1 and 2, and they're both above 2.5 millimeters. In the first one, we have 4.6 and then 4.2. And this is clearly a bowel wall, a bowel wall that is thickened. And also you can see here that is a little loss of stratification here in this part, but the other part is preserved. And in the second image, as you can see, this is the Doppler mode, and here we have dots and lines across the bowel wall. And I would say that in this image, they go across the bowel wall, and they continue to the mesenteric fat and to the tissues adjacent to it. So I would say that this is a Limburg tree. And then this was the image of the ileocolonoscopy, that all of the colon was of the bowel and the large bowel was involved. And then we had the diagnosis of an ulcerative colitis, and he was started on prednisolone. So in this clinical case, you can see that for the diagnosis, it is really important and it's really accurate, and you can see the extent of the disease. And for another this second case, another scenario, the second case is a 14-year-old girl with known Crohn's disease who is clinically asymptomatic while receiving azathioprine. And on May 2025, she was clinically stable with no abdominal pain, diarrhea, or systemic symptoms, but her fecal calpro raised to 600. And then we perform an intestinal ultrasound, and this is what you see. Once again, what pathologic findings can be identified? I'll give you a few seconds if you want to take a closer look. And then we're going to identify them together. So here is the ascending column, okay, and this was the only part that was affected. And here you can see that this is the bowel, this is the anterior wall, this is the posterior wall, and here we have the lumen, this white line here, mucosa submucosa muscularis, and once again, the bowel wall thickness, the bowel wall is thickened, and we have 6 millimeters of bowel wall, which means that there is an active inflammation. And in the second image, here we can see that we have the more vascularization, the color Doppler is active, and we can see that also the signals are also lines that go, these ones don't go through the bowel wall, so I would say this is a Limburg 2. And with this image, even though the patient was clinically stable, we asked to do an upper endoscopy and colonoscopy were proposed, but the parents declined because the patient was fine and they refused to do it. So 2 months later, the patient remained clinically asymptomatic, but the fecal calpro raised to 4,200, and the erythrocyte sedimentation rate was 52, and the CRP was 0.6. Then we had this intestinal ultrasound, and as you can see here, there is a thickening of the bowel wall. And this last part of the image, this is the psoas muscle, the iliac vessels, and then this is the terminal ileum, which is completely normal, right? In this image, it is not measured, but you can see it's normal. And I'll show you again this loop. And as you can see here, I'll use the pointer. So this is, I'll show you again, this is the terminal ileum, this is the iliac, these are the iliac vessels, and this is the psoas muscle. And once again, I'll try to use the pointer. Here is the ascending column, okay? And this shows the ileocolonoscopy where the ascending was really affected, and then she was started on infliximab, and right now she is great. So I think that this case highlights how intestinal ultrasound can detect silent disease activity and how it can be useful in our daily practice. And I think for future perspectives, several exciting developments are emerging. First one is the assessment of transmural healing. That I think that in a short period of time we will be able to do. Then the characterization of stricturing disease and the degree of fibrosis, not only with elastography alone but also combined with contrast enhanced ultrasound. That can be used also in these patients, but takes longer, and it's not that easy to perform, but it can be used. Also, it will be the intestinal ultrasound will be really useful in the evaluation of functional impairment, because it has the unique characteristic that we can see the bowel movement that we cannot in MRI or in CT. Also, it can be used in pregnancy with safety, and it can assess these patients until the second trimester with an accuracy that is really good. And I think that the future will be, of course, the implementation of portable ultrasound devices that are connected to our cell phones, and that we don't have to use the big machine, and we can use the ultrasound probe, and we can do it in our daily practice. So as As conclusion, I would say that intestinal ultrasound is a key tool for the diagnosis and monitoring in pediatric IBD. It is safe, non-invasive, and repeatable. It detects persistent subclinical inflammation, enabling early, effective, and personalized treatment. And it also supports a preventive approach focused on improving patient quality of life. Just to finish my presentation, I would like to highlight the ESPGHAN Intestinal Ultrasound Hands-on Qualifying Program, which aims to provide pediatric gastroenterologists with standardized skills in performing and interpreting intestinal ultrasound. Basically, it is formed by 4 steps. The first one is an online theoretical introduction to intestinal ultrasound in the pediatric patient that consists of 3 to 4 hours, and it is usually performed within 2 to 4 weeks prior to the hands-on event that is performed on the ESPGHAN Congress annually. Then we have the step 2, which is the hands-on event of 2.5 days, where the selected participants will participate in numerous hands-on sessions in small groups with models and with real patients, and will be led by ESPGHAN intestinal ultrasound experts. Then the step 3 will be an hands-on practice where the participants will have to do at least 50 examinations, and they can do it and they can perform it in an ESPGHAN approved qualifying center. And finally, the step 4 is an advanced workshop that will include lectures and case presentations of complicated intestinal ultrasound IBD patients. And this step will only be available for participants who successfully complete step 1 to 3. And at the end of step 4, you'll complete the test, and then you'll be certified to perform intestinal ultrasound. Of course, this is not the end. This is just the beginning. You have to practice a lot, and when you'll have a lot of doubts and you will have difficulties, but that's the beautiful of it. The beautiful part of it is that you can share your doubts with your colleagues, and you can help our patients in a more precise way, and with the treat to target idea in mind. Thank you so much.
Thank you very much for this presentation. So as a person that has completed the first 2 steps, I can confirm that it's a great opportunity to learn more about the intestinal ultrasound. So I also encourage you to participate. So now, if you have any questions, just please write them in the chat or in the question Q&A tool. We still have a couple of minutes, so I would like to start with a short question. Is it okay to compare the thickness of one part of colon with the other part of the same patient? So if we know that maybe I don't know, like you said, the ascending was the one that was affected, can you compare it with the descending colon?
That is a great question that you're asking, and right now in pediatric population we still don't know if the bowel thickness is the same for all of the bowel. So we can compare for example, in the ascending colon, and we can compare if it is the same or not, but we cannot say, for example, that comparing the ascending to the TI, because it's not the same. Okay. Because the values that we can consider can be different, and we must have knowledge of that.
Because I had some patients that were like 2.5 millimeters was quite high, and you could see that the stratification was also affected. We had some Doppler signal, so it wasn't, even though it was less than 3.
Yes, that's really important, because when we are talking about these parameters, we must combine them. We cannot say that if it is 2.5 or 3 or 3.5, then we have inflammation alone. We have to combine all of them, and we have to also combine with this with clinical aspects and with biochemical parameters. And this way, we will have a better view of our patient. But I had the same doubts when I was starting this, and. Uh, Before in adult population, they say it is inflamed above 3 millimeters, but in pediatrics, you can see that between 2.5 and 3 millimeters, you will have inflammation, definitely.
Also, a question about, so we have a question from Marco. He's asking about standard Doppler versus SMI, and what velocity scale do we need to use?
Usually what we do is we turn the Doppler to the maximum to try to have it like saturated, and then we go and we start diminishing the Doppler sign, and it's usually between -5 to 5, usually about that.
And you do it on a vessel, so on our
No, I usually perform it at the bowel.
the,
Yes, the
okay.
anterior wall of the bowel.
And second question also from Marco about peristalsis. Is there some observation time needed or some other criteria to say that it's reduced peristalsis?
When you have a certain experience, you'll start to differentiate what is a normal peristalsis and what is not. But of course, you have to have your probe on the patient to see if it's moving or it's not. I don't know if this exactly the question that is being asked, because sometimes it's difficult to differentiate from the colon to the small bowel. It's difficult, and when it moves, you can differentiate it. You can see the difference. I don't know if this is the question.
I hope so. I hope we answered your question. So also you said that the rectum is really hard to see. So, and also in your sheet you didn't actually add. I think you didn't add the rectum. So is it okay if we don't give information about the rectum if we don't actually?
You won't be able to see it with the usual transabdominal approach that we have, unless the rectum is really inflamed, and then you can see that it's wider. Then you won't be able to see it with the convex probe. So the only approach that you can use, but it's not, you have to have practice. And personally, we are not performing in our unit still the transperineal approach. With the transperineal approach, you can see the differences, but we do not usually include the rectum in our assessments because it's not accurate, because it is really deep in the pelvic the pelvic region, and the parameters, it's not accurate really.
Okay. And also you said that there's no need for preparation, but are there some special, I don't know, opportunities like when you actually do some preparation,
Yes.
like maybe you use mannitol or like for enter MRI or?
So it's one of the things here, and I think that intestinal ultrasound is so useful because patients do not need fasting or other preparation, and they do not need to drink or another type of mannitol or something like that. Of course, if you want to perform another type of exam, for example, the contrast enhanced ultrasound, where you can put an IV line and you can do a more structured study, you can have another preparation. And if the patients have like 3 to 4 hours fasting, you will be able to see the things that you won't if they had just eaten before. Okay, but if we say patients that you cannot eat or you need to prepare for this exam, that then you won't have the benefits of this exam that you will do it on bedside. I think this is critical.
Okay. So I think I don't know if we have any more questions, but our time is quite up. We are on time. 1 hour already has passed. Thank you so much for this great talk. I think it's like the intestinal ultrasound, it's still at the beginning, especially for the pediatric population. And I think that we need to gain more experience in order to maybe to have more questions.
Yes. Thank you so much. And with this presentation, I hope that everyone is really excited and register at this ESPGHAN Congress and the intestinal ultrasound training curriculum. And we really want to share the knowledge and to help our patients with this type of monitoring. Thank you.
Yes. Thank you so much for accepting
Thank you so
our
much. Bye-bye.
invitation,
Take care.
and thank you all for participating, and see you next month to our next webinar. Thank you again for everything.
Thank you.
Have a great day.